Sleep Disorders, a Biopsychosocial Review. Sleep plays a vital role in restoring both body and mind. Yet, millions of people worldwide experience chronic disturbances that affect their physical health, emotional stability, and cognitive performance. In this presentation, we'll look at sleep disorders through a biopsychosocial lens, meaning we'll consider biological causes, psychological patterns, and social contexts that all interact to create and maintain these conditions. We'll also explore evidence-based treatments, such as behavioral and medical interventions, and review validated assessment instruments that help clinicians measure sleep problems with precision. Assessing sleep disorders, why it matters. To understand sleep problems, we need tools that turn subjective experience into measurable data. Sleep is not only biological, it's also deeply psychological and social. Reliable assessment instruments help identify how these dimensions interact. Three of the most widely used tools are the Insomnia Severity Index, or ISI, which focuses on the nighttime experience of insomnia, the Epworth Sleepiness Scale, or ESS, which measures daytime sleepiness, and the Pittsburgh Sleep Quality Index, or PSQI, which evaluates overall sleep quality. Together, these instruments help researchers and clinicians link brain and body functions to thoughts, emotions, and daily performance, offering a comprehensive picture of how sleep problems manifest in real life. Insomnia Severity Index, ISI. The Insomnia Severity Index, or ISI, is a short questionnaire that captures both the symptoms and the emotional impact of insomnia. It asks 7 questions rated from 0 to 4, covering issues like difficulty falling asleep, staying asleep, early awakening, dissatisfaction with sleep, and the level of distress these problems cause. Scores range from 0 to 28, with higher values indicating greater severity. Because it's quick to administer and highly reliable, the ISI is used across many populations, from students under stress to patients with chronic illness. Its design reflects the biopsychosocial approach by linking physical sleep patterns to cognitive and emotional responses, helping clinicians understand not just how people sleep, but how they feel about their sleep. ISI validity and clinical use. The ISI isn't just practical, it's also scientifically robust. Research by Morin and colleagues shows that it distinguishes insomnia from normal sleep with more than 85% accuracy. It also correlates strongly with anxiety, depression, and fatigue scales, confirming that poor sleep rarely occurs in isolation. Even more importantly, the ISI is sensitive to treatment effects. When scores drop by about 80 points or more, that usually means a meaningful clinical improvement has taken place. This makes the ISI not only a diagnostic instrument, but also a valuable tool for tracking progress in cognitive behavioral therapy for insomnia, or CBTI, and in pharmacological treatments. Epworth Sleepiness Scale, ESS. The Epworth Sleepiness Scale, developed by Jones in 1991, measures how likely someone is to fall asleep during daily activities, like reading, watching TV, or sitting in traffic. By asking participants to rate 8 such situations from 0 to 3, clinicians can quickly assess whether excessive sleepiness might signal an underlying disorder. Scores above 10 suggest abnormal sleepiness, while 16 or higher usually points to a serious condition like obstructive sleep apnea or narcolepsy. Because it is easy to complete and correlates well with laboratory tests of sleep latency, the ESS remains one of the most practical instruments for identifying daytime consequences of disrupted sleep. Pittsburgh Sleep Quality Index, PSQI. The Pittsburgh Sleep Quality Index provides a global view of sleep patterns. It includes 19 self-rated questions grouped into 7 domains, such as sleep duration, efficiency, disturbances, and use of medication. A total score higher than 5 typically indicates poor sleep quality. What makes the PSQI powerful is its ability to connect sleep complaints with mental health outcomes, including anxiety, depression, and stress-related disorders. Because it captures both behavioral and emotional aspects, the PSQI aligns perfectly with the biopsychosocial model, showing how psychological distress, lifestyle habits, and environmental factors together shape the experience of sleep. Integrative summary: instruments in context. Each of these instruments adds a unique perspective. The ISI focuses on nighttime distress and cognitive worry about sleep. The ESS reflects the daytime consequences, how fatigue interferes with function and alertness. And the PSQI integrates both dimensions, offering a broad measure of sleep quality that relates to physical health and emotional well-being. When used together, they give clinicians a multidimensional view that bridges mind and body. This integrated assessment allows for more personalized interventions, from behavioral therapies to medical treatments, while reinforcing the core principle of health psychology, that true understanding of sleep requires attention to the whole person, not just the symptoms. Biopsychosocial etiology of sleep disorders. Sleep disorders emerge from the dynamic interaction between biological, psychological, and social systems. From a biological perspective, changes in brain chemistry, hormonal regulation, and stress physiology can predispose individuals to sleep disturbance. Psychologically, cognitive patterns such as worry or rumination reinforce hyperarousal and interfere with relaxation. And social pressures, from work schedules to family demands and digital exposure, maintain irregular sleep behaviors. When these layers interact, they form a feedback loop that sustains insomnia. By viewing sleep through a biopsychosocial lens, clinicians can move beyond symptom control toward integrative approaches that restore balance across the body, mind, and social context. Biological and psychological dimensions, the 3P model. One of the foundational frameworks in sleep psychology is the 3P model of insomnia developed by Arthur Spillman. It proposes 3 key contributors: predisposing, precipitating, and perpetuating factors. Predisposing factors include biological traits like heightened arousal or an anxious temperament. Precipitating factors are life stressors, such as illness, emotional distress, or major transitions that trigger sleep disruption. And perpetuating factors are the maladaptive behaviors people adopt to cope, like staying in bed awake, napping excessively, or extending time in bed to catch up. Together, these elements explain how acute insomnia becomes chronic, guiding treatments that reshape habits and restore natural sleep regulation. Developmental and contextual factors in adolescence. Adolescence is a particularly vulnerable stage for sleep problems because biological, psychological, and social changes all converge. According to Becker and colleagues, puberty brings a natural shift in their circadian rhythm, making teens all fall asleep later, yet school schedules rarely adapt. At the same time, emotional regulation is still developing, and increasing use of screens and social media adds stimulation when rest should happen. These factors interact with stress, identity formation, and peer pressure, forming a perfect storm for chronic sleep deprivation. Understanding these developmental layers help design age-appropriate interventions that address not only behavior but also environment and lifestyle. Social determinants and health disparities. Sleep health doesn't exist in a vacuum. It's shaped by where and how people live. Williams and colleagues show that socioeconomic status, racial discrimination, and neighborhood stress can all erode sleep quality. Chronic exposure to violence, noise, or unsafe conditions keep the nervous system in a state of alert, promoting insomnia and fatigue. At the same time, limited access to health care and cultural stigma may prevent individuals from seeking help. This makes sleep a social justice issue. Improving it requires policies that address inequality, access to care, and safe environments, not just bedtime routines. Integrated biopsychosocial synthesis. When we integrate these perspectives, insomnia appears not a single disorder, but a systemic imbalance involving mind, body, and environment. Biological hyperarousal interacts with psychological factors like worry and perfectionism, while social pressures, from technology to economic stress, maintain the cycle. This interplay creates what health psychology defines as self-perpetuating regulation failure. The body stays awake when it craves rest. By treating sleep within this full biopsychosocial context, interventions become more precise and humane, addressing both the symptom and the system that sustains it. Circadian rhythm sleep-wake disorders. Clinical overview. Circadian rhythm sleep-wake disorders happen when the body's internal biological clock falls out of sync with the external world. In these cases, people often experience insomnia, early awakenings, or excessive sleepiness, not because they can't sleep, but because their sleep occurs at the wrong time for social or work demands. To evaluate these disorders, clinicians use tools like actigraphy, sleep diaries, and laboratory tests that measure melatonin secretion, especially the dim light melatonin onset, which helps identify whether someone's rhythm is delayed or advanced. Treatment focuses on realigning internal and external time through chronotherapeutic methods, using controlled light exposure, carefully timed melatonin, with structured routines for meals and activity. This approach restores synchrony between the body's circadian clock and the environment. Light therapy for delayed sleep-wake phase disorder. For individuals whose sleep cycle is shifted too late, often falling asleep at 2 or 3 a.m., light therapy is one of the most effective treatments. Research by Gomez and colleagues shows that exposing patients to 10,000 lux of bright light shortly after waking, usually for about 30 to 45 minutes, can shift their internal rhythm earlier by 1 to 2 hours. This works because morning light suppresses melatonin and resets the brain's master clock. Consistency is crucial. The treatment must occur at the same time daily, ideally combined with good sleep hygiene and avoidance of bright light in the evening. Blue-enriched light has been shown to produce stronger results. When properly timed, phototherapy helps synchronize alertness, mood, and performance with desired daily schedules. Melatonin and chronotherapeutic regulation. Melatonin is not just a sleep aid. It's a biological signal that helps regulate the body's timing system. Studies by Wikniak and colleagues show that for delayed sleep-wake phase disorder, taking melatonin 6 to 8 hours before the desired bedtime can advance sleep onset effectively. For those with an advanced phase who fall asleep too early, lower doses may be used later at night to delay the rhythm instead. The usual therapeutic range is 0.5 to 5 milligrams, with higher doses used temporarily at the start of treatment. The best outcomes occur when melatonin is combined with light therapy and behavioral changes, such as adjusting meal times, social interactions, and physical activity to reinforce the body's 24-hour rhythm. Most treatment cycles last 3 to 6 weeks and can be repeated to maintain alignment. Cognitive Behavioral Therapy for Chronic Insomnia. CBTI is recognized as the first-line treatment for chronic insomnia. Unlike sleeping pills, which can lead to tolerance and dependence, CBTI produces long-lasting results by addressing the underlying causes of poor sleep. A major meta-analysis involving more than 1,000 participants found clear benefits. People fell asleep about 20 minutes faster, stayed asleep longer, and increased their overall sleep efficiency by nearly 10%. The treatment combines cognitive restructuring, stimulus control, sleep restriction, relaxation, and sleep hygiene to help the body and mind relearn healthy sleep habits. These findings position CBTI as the gold standard, a scientifically proven non-pharmacological method to restore the natural sleep-wake cycle. CBTI and quality of life. CBTI doesn't just improve sleep, it transforms quality of life. A meta-analysis by Ali Moradi and colleagues covering nearly 2,000 participants showed a moderate but consistent effect across populations. After completing CBTI, participants reported better emotional balance, less daytime fatigue, and lower symptoms of anxiety, depression, and pain. This means CBTI acts not only as a behavioral treatment for insomnia, but as a biopsychosocial intervention that restores functioning across mental, emotional, and physical domains. By improving rest, CBTI helps rebuild psychological resilience and supports healthier daily performance and mood. Digital CBTI and long-term effectiveness. The digital transformation of CBTI, often called DCBTI, has made this therapy far more accessible. Online programs, whether guided by a therapist or completely automated, have shown results equal to traditional in-person sessions. Participants experience less insomnia, anxiety, and fatigue, and many maintain these improvements for up to a year. Digital CBTI also encourages adherence because people can practice at their own pace, privately and conveniently. By bringing evidence-based treatment into digital healthcare platforms, CBTI becomes not just a clinical tool, but a scalable public health solution for sleep disorders.